Hi, friends. This is Dr. Rahul Pandit back again with popular demand and a lot of pursuance from our students. They wanted to know what molecule should be using and what dose we should be using for thromboprophylaxis. So we are coming to the version 2 of our talk, which is which molecule and what dose. Well, let's get going with this over the next 6 minutes. First and foremost, let's rule out what are the contraindications. Again, a common sense approach is required, as I said before. If you've got active bleeding, if the platelet count is less than 20,000, if you've got impending surgery, if you've got coagulopathy, all of these would obviously refrain you from starting a patient on thromboprophylaxis or anticoagulation. However, that does not mean that a patient does not get any form of protection. You need to start them on mechanical calf compression devices unless they are contraindicated as well. Now, let's talk about VTE prophylaxis in detail. What are the options? The three options we already know: unfractionated heparin, low molecular weight heparin, and fundoperinox. We also know that the ACCP, ASH, and NICE guidelines have clearly said that the direct acting oral anticoagulants are not something which we should be using for prophylaxis in ICU. So, what does that leave us with? It leaves us with unfractionated heparin, low molecular weight heparin, and fundoperinox. However, to decide what dose and what regime we should be using, we need to understand some basic characteristics of these drugs. So let's get going with this. Heparin, low molecular weight heparin, and fundoperinox. Heparin acts on factor 10A and thrombin, whereas low molecular weight heparin acts on factor 10A and factor 2A. Fundoperinox acts exclusively on factor 10A. Half-life of heparin is only 1 hour, whereas because the renal function is actually a very important integral part of the clearance of low molecular weight heparin. If it is normal, the half-life is between 3 to 6 hours. And fundoperinox, obviously, it's got a very, very long half-life, 18 to 21 hours. The heparin is metabolized in reticuloendothelial system, whereas 40% of low molecular weight heparin is metabolized in the kidneys. Hence, that importance of half-life with the normal kidney function. And again, there is a significant renal clearance for fundoperinox as well. When you monitor, well, you need to monitor, unfortunately, heparin quite extensively. You need to do serial checks with APTT, whereas there is no need to monitor low molecular weight heparin or fundoperinox. Renal failure, you are safe to use the low molecular, you safe to use unfractionated heparin, whereas low molecular weight heparin and fundoperinox are contraindicated if your GFR is less than 30. Antidote, luckily you have an antidote in form of protamine for unfractionated heparin. However, for LMWH, protamine may only minimally act and not really reverse action. And fundoperinox has got, unfortunately, no antidote and has got a very long half-life. What about heparin-induced thrombosis? Well, around 3 to 5% patients on heparin will actually have HIT, whereas low molecular weight heparin, the risk is extremely low, and there is absolutely no risk with fundoperinox. What's the prophylactic dose? Low molecular weight heparin dose is 40 milligrams subcutaneously daily if it is using enoxaparin and deltaparin 2,500 units or to 5,000 units subcutaneously daily. For heparin, the dose is 5,000 units subcutaneously twice a day, and fundoperinox, the prophylactic dose is 2.5 milligrams subcutaneously once a day. What about therapeutic dose? Well, for heparin, the therapeutic dose is loading 2,500 to 5,000 units intravenously, and then you need to give an intravenous infusion of 50 to 100 international units per kg per hour to be keeping an APTT between 1.5 to 2 times the baseline of that particular patient. What about clexane? Well, enoxaparin given in 1 milligram per kilogram twice a day is a very, very good anticoagulant dose, and deltaparin 10,000 units subcutaneously daily. Whereas for fundoperinox, if you've got a patient less than 50 kgs, 5 milligrams, 50 to 100, 7.5 milligrams, and more than 110 milligrams subcutaneously daily is to be given. Now, let's look at some special conditions: head injury, postoperative, subarachnoid hemorrhage, pregnancy, coagulopathy, oncology, head injury. Day one, always start them on mechanical calf compression devices. If it's a closed head injury, in 72 hours, you can start on pharmacological prophylaxis. If there is space occupying bleed, external ventricular drain, postoperative patient, then case by case, you need to decide and take a call on pharmacological prophylaxis in a few days' time. Until then, continue with the SCDs. Postoperative patient, hip and joint, perioperatively also you need to give, and at least 2 to 4 hours postoperatively, you need to start them on some form of pharmacological prophylaxis if there is no contraindication. Routine, any postoperative patient who comes to ICU should receive pharmacological prophylaxis for DVT until they are in the intensive care unit. And cancer surgery, you should start the prophylaxis as soon as possible, immediately after the surgery. What about subarachnoid hemorrhage and intracranial bleed? Where subarachnoid hemorrhage, as soon as the aneurysm is clipped, you are safe to start pharmacological DVT. For intracranial hemorrhage, unfortunately, there is no clear demarcation or studies which can actually tell you that you can start it at this point. Hence, a case-to-case understanding has to be taken up on these patients. Mind you, that patients who are on dual antiplatelet as well as they receive a DVT prophylaxis stand a very high chance of bleeding. So just be careful about those patients. What about coagulopathy? Well, it's contraindicated in active bleeding to give any form of prophylaxis. If the platelet count is below 40,000, be cautious. If it is below 20,000, contraindicated. Liver failure and surgery, a special cautious approach to patients with high grades of encephalopathy. You may choose to give them low molecular weight heparin or unfractionated heparin as a DVT prophylaxis. In pregnancy, low molecular weight heparin is safe. There is absolutely no reason why we should not be giving them if they are in the intensive care unit. And if they have another prothrombotic condition like the protein S or protein C deficiencies, then they can be actually given a therapeutic dose of low molecular weight heparin as well. All oncology patients have got a very prothrombotic condition, and they all should be given the low molecular weight heparin for DVT prophylaxis unless contraindicated. And contraindication is because they usually have a low platelet count as well as coagulopathy. So let me summarize. DVT prophylaxis can be given in form of SCD or pharmacological prophylaxis. Special conditions warrant a deeper understanding before starting pharmacological prophylaxis. Renal clearance needs to be taken into consideration when dosing the drug. So friends, I will come back to you with the next video. I hope you like this video. And I would be saying that we now conclude the thromboprophylaxis part of this session. We move on to some newer topic. See you then. Thank you.